Bismillahirrahmanirrahim. In this video, I'll try to discuss the topic of evidence-based physical examination and discuss why this is important. We will tackle some questions like, are physicians' physical examination skills deteriorating? How much physical exam can make a difference in the presence of new test and diagnostic modalities that we have in 2021? What are the likelihood ratios and how they can help make a diagnosis? What is hypothesis-driven physical examination and how is it different from the traditional physical examination that we used to do or we used to learn in medical school? What are the resources to learn evidence-based physical examination? So let's get into it. Generally, in the medical community, there seemed to be some concern recently about the skills that we have in terms of physical examination. But to be honest, there are a lot of data and some reports that actually dated back to the 70s and even the 80s that there's some concern about the deterioration of physical examination skills. So in my opinion, it seems like this is kind of the natural history of physical exam skills among physicians. And this partly could be due to the fact that now we recently have more advanced technologies. That doesn't mean necessarily this is a bad thing or good thing. So we'll discuss that in more details. So we know that physical examination comes after history as a foundation for making diagnosis. We know that physical exam can be diagnostic in some cases and some diseases. We also know that physical exam is cheap, and mostly harmless, and in some report might even build some rapport between you and your patient. But at the same time, we also know that generally physical examination has less sensitivity and specificity than many lab tests and imaging. So the real question was, those with good physical examination skills, can they make a difference in diagnosis compared to those, for example, with less experience in physical exam? So Riley tried to answer that specific question. So he did an observational study, comparative study, where 100 patients were admitted to their hospital, and these patients were seen by ED physician, an ED resident, and a medical resident, and admitted to the inpatient medical floor. And then within 7 hours, the senior physician who wrote the paper, he saw all these patients within 7 hours of admission. He's basically an academic hospitalist. He's a senior physician. He had been in practice for 25 years or so at the time of the paper. So he sees this patient, and then he he does his physical examination, and then he determines whether he agrees or disagrees with the admitting diagnosis and the medical resident, ED physician's assessment and plan. So there's a panel of 3 senior physicians. They looked into this senior physician Riley's physical exam findings and the findings of the admitting staff, and they determined whether there's any pivotal physical exam findings. Their definition of a pivotal physical finding is that, number 1, it's detected by bedside physical assessment, using the classic physical examination components: inspection, palpation, percussion, and auscultation. So it's basically a physical exam finding. And then number 2, this exam finding prompted revision of the patient's initial diagnosis made by the admitting staff. So it prompted a question regarding whether that initial admission is correct or not. And then not only that, but also this physical finding led to a major change in the management plan. And also the fourth and last one is that this pivotal physical exam finding have to be agreed upon by 3 members of a panel of senior physicians. So they further classified these findings into validated physical sign, which basically a physical examination finding that led to active collaboration of a consulting specialist. So basically, not only the management was changed, but a consultant physician from other specialists was also requested to evaluate the patient. And then discoverable sign is basically physical examination finding that can potentially be discovered by other diagnostic tests. CT scan, MRI, ultrasound, lab test, any other test other than physical exam can potentially discover this physical examination finding. For example, if the senior physician discovered hepatomegaly that was not discovered by the admitting staff in a patient with severe abdominal pain who is most likely needing imaging of the abdomen, that physical examination sign is said to be discoverable, meaning most likely the CT scan or MRI or ultrasound will be able to detect that physical finding. And then what they're looking for is class 1 signs. So class 1 signs are basically physical exam signs that deemed to be validated, that it led to consulting another specialist, but also not discoverable. That is, it's unlikely to be seen by other diagnostic modality. And this is the results. So basically the total of 26 pivotal physical findings were agreed upon by the panel that were discovered by the senior physician, and 7 of them were actually class 1 physical examination finding. And I think this is really kind of a decent number. So in 7 cases, this physical exam finding, different from the admitting staff, they actually led to a change in the management plan, and it prompted consultation for proper management, and they're less likely, or they're not really discoverable by other measures. So I think that's really kind of give a good idea that physical examination can really be useful if done in an appropriate way. So you can look at the paper and to see like some of the examples that were mentioned. I'm bringing here kind of a couple of them just to go over them, which I think is kind of interesting. So for example, one of the patients, his or her initial diagnosis was staph bacteremia from arm cellulitis, and the patient was started on IV antibiotics. The senior physician discovered a tender antecubital cord, and he suggested that this patient might have suppurative thrombophlebitis. And the treatment of that is different because in most cases you need surgical removal of the infected thrombus, and that's what happened. They consulted surgery, and they did surgical thrombovenectomy in addition to the antibiotics. Another patient was admitted with fever, suspected UTI, and was started again also on IV antibiotics. On his physical examination, he found a dusky big toe, and he suggested that the fever is probably from the toe gangrene rather than a UTI, and patient ended up having a toe amputation. Another patient was admitted with delirium. Patient was started on haloperidol and had some CNS imaging to look for the cause of the delirium. On his examination, he found that the patient has psychomotor retardation, and his attention span is actually normal. I would suggest in this regard that patient with delirium, you try to do some objective testing for attention. I usually like to do the 6 serial backward mentioning of the month. So anyways, in this case, attention span was normal, and psychomotor retardation was evident by the physical examination of the senior. So he made a diagnosis of major depression, which we all know that sometimes can mimic delirium. The patient, instead of antipsychotic, he was started antidepressant and had intensive psychiatric care. The last example, a patient was admitted with a diagnosis of unstable angina, presenting with chest pain. He was started actually on heparin and aspirin, but the senior physician found that the patient had C8 radiculopathy with weakness, and he suggested diagnosis of cervical disc herniation rather than ACS or acute coronary syndrome, and the patient ended up having laminectomy. So I thought that's really cool examples, and some of these really very simple, like this case here, it's really by observation. It's just telling us that sometimes simple physical examination finding can be missed, sometimes even easily. It doesn't have to be like a sophisticated maneuver to help us make the diagnosis. Sometimes just simple observation, and that's something that I always emphasize to my medical residents to keep in mind.